Good afternoon, good morning, and welcome to this global webinar series covering knowledge and future directions in psoriasis by International Psoriasis Council. The title of this webinar is How to Prepare for Another Pandemic. And we are very grateful to our sponsors, Abby and Eli Lilly and Company. This webinar will last 60 minutes, is being recorded, and the audio is muted. So we are asking you to make your questions through the question and answer in the chat. Recording will be available at psoriasiscouncil.org. And I would like to introduce the International Psoriasis Council for those of you who are not well acquainted with our goals. The International Psoriasis Council was founded in 2004 and is a dermatologist-led voluntary global non-profit organization with a network of more than 100 psoriasis experts, thought leaders, and professionals. We are dedicated to improving patient care around the globe. And our vision is a world free of psoriasis. That means that no matter how complex the symptoms of our patients with psoriasis are, they should have access to the best available care. And ultimately, a world without psoriasis is possible. And our mission is to improve the care of people with psoriasis worldwide through research, education, and advocacy. And our network of psoriasis experts includes 128 board members and counselors representing 37 countries, and they volunteer their time to implement our programs and activities with a very large participation. These are the key areas of focus. That's access to care, research, medical education, and global outreach. And there's a quite interesting online knowledge center that is located at our website and includes a video series that take 10 minutes, on-demand symposia, video library, a calendar of events, congress reports, a fellowship program, a psoriasis review newsletter, and a COVID research center. And this webinar will be available also in the repository of videos. And there are 4 of the previous webinars have already been included in that repository. And coming soon will be this video, How to Prepare for Another Pandemic. And I would like to introduce our faculty. We have Dr. Salvir Mahil from St. John's Institute of Dermatology, Guy's and St. Thomas National Health Services Foundation Trust in London, England, United Kingdom. Then we have Dr. Ulrich Mrowitz, University Medical Center, Schleswig-Holstein in Kiel, Germany. And finally, Ricardo Romiti. Dr. Romiti is a member of the University of Sao Paulo, Brazil, and he is also an International Psoriasis Council board member. And we're going to discuss infections in psoriasis, the experiences from the SARS-CoV-2 registry, vaccination and immune responses, and we'll have a section for comments and discussion. So our first talk will be done by Ricardo Romiti. He's responsible for the psoriasis unit at the Department of Dermatology of the University of Sao Paulo in Brazil, and works as a clinical professor of dermatology also at the University of Sao Paulo, and he's an International Psoriasis Council board member. And we'll talk about infections in psoriasis patients treated with small molecules, biologics, or their combination.
Great, sorry. So this is my hospital in Sao Paulo, where I work. So when we think about infections and psoriasis treatments, we know there might be an association between specific treatments for psoriasis and infection. So we all know the association between anti-TNF treatment and tuberculosis, the use of anti-IL-17 blockers and candidiasis and widespread dermatophytes infections, and even of the association of JAK inhibitors and the occurrence of herpes zoster, for example. But is there also an association between psoriasis as a disease and infections? Is the occurrence of infections higher in psoriasis patients? We know that for superficial bacterial infections, the risk is actually lower. We know that due to the enhanced production of this antimicrobial protein genes, the frequency of these kinds of infections tends to be much lower than in atopic dermatitis patients and even in patients with hidradenitis suppurativa. Concerning systemic infections, we know that there might be a higher risk of this kind of infections. We have interesting data from this Dutch study following over 25,000 patients during a 6-year period, showing that the risk of infections requiring hospitalization was higher in psoriasis patients when compared to the general population. And interesting that the magnitude of this risk was not associated with specific therapy of these patients, but much more with the severity of psoriasis. And we also know that erythrodermic and GPP patients are much more prone to have serious systemic infections. And what about biologics? Is there a higher risk for our psoriasis patients? If they have infections, when do these infections tend to happen? These are an interesting comparison actually from the rheumatology registry, showing that when we use biologic treatments, the chance of having serious infections is much higher during the first months of therapy, especially when we compare those patients treated with DMARDs as methotrexate, when this risk is much higher after a long period of treatment. The same data for hospitalization, here Swedish registry data, showing that at the first year, the risk of infection is much higher with biologic treatments. And what about the risk itself? We have very well done systematic reviews and meta-analysis of the literature. Here, looking firstly at anti-TNF treatments, showing that when we consider etanercept, adalimumab, and ustekinumab, there tends to be not a higher risk of these infections. Looking at registries, here we have the results of the British Association of Dermatologists register, also showing not a significant increased risk of serious infections when we look at patients treated with etanercept, adalimumab, and ustekinumab, especially when compared with methotrexate or other psoriasis treatments. Here, data from the Spanish registry, BioBadadem, following over 2,000 patients between 2008 and 2015, showing that TNFs as a group had a higher prevalence of overall infections, and within the group of anti-TNFs, infliximab showing the higher risk, and ustekinumab having the lowest overall infection risk among biologic treatments. Similar data we have from this SOLAR registry, where we see at the left the risk of serious infections with ustekinumab much lower when compared to anti-TNF treatments and also to no biologic treatments. When we now shift to the newer anti-interleukin blockers, ranging from IL-17 blockers to IL-23 blockers, we see that the safety profile is present. Specifically, when we look at serious infections, we see that with all these drugs from both groups, the prevalence of serious infections and of overall infections is very low. Now, considering tuberculosis, we know this is a very specific issue when we treat our patients with anti-TNF drugs, especially here in Latin America. We know that one of the serious side effects of anti-TNF treatment when we consider infections is tuberculosis. Why does this happen? We know that when we use these TNF blockers, we have a much higher risk of reactivation of tuberculosis. This might be as far as 9 times higher than within the normal population. We know that TNF has an important role of keeping the tuberculosis granuloma at its place. And when we start blocking TNF, we have a breakdown of this granuloma, allowing for the dissemination of Mycobacterium tuberculosis. So sometimes we don't have classic tuberculosis only, like pulmonary or pleural tuberculosis. We might have extrapulmonary cases, like this patient of ours developing a peritoneal tuberculosis during anti-TNF treatment. Another case, a very rare case of ocular tuberculosis occurring. and an even much rarer case of tuberculosis affecting the tongue. This was the only site of involvement at this patient. He didn't present any other signs of symptoms of infections like fever or malaise. The only site of involvement was the tongue. And the only way to really make the diagnosis possible was with a very deep surgical biopsy. So we know that we have to screen our patients for latent TB, not only looking at the X-ray as the quantiferon or PPD, but specifically at the previous history of our patients or contact with tuberculosis. And we know that since we started doing this screening, the incidence of reactivation of tuberculosis dropped a lot. Here we see data from infliximab. Since the time, about the year 2001, this screening started to be done, we see a constant drop of the TB reactivation rates. When we look now again to the IL-17 and IL-23 blockers, and of course also to the IL-12 and 23 blocker, ustekinumab, we see that data in regards to reactivation for tuberculosis is very comforting. We know that the rates are extremely low. We have very few cases published in the literature of reactivation of tuberculosis when we use these neuromodality treatments. Candidiasis is another specific issue. When we think of blocking IL-17, we know that IL-17 has a specific role of blocking fungal infections, and that's not a surprise when we look at data from secukinumab, ixekizumab, and even higher rates when we think of bimekizumab, the IL-17 blockers that blocks IL-17A and IL-17F, when we have higher rates of candidiasis. Here we see a rate of about 3.5% of patients being treated with secukinumab developing this kind of fungal infection. And what about the small molecules? Concerning apremilast, the data we have from literature, not only concerning common infections like respiratory upper tract infections, but also herpes zoster, hepatitis C, and even tuberculosis. We also see that the rates are extremely low when we use this phosphodiesterase 4 inhibitor. And what about the JAK inhibitors, the neogenous kinase inhibitors? We know that these inhibitors block the enzymes, the JAK-STAT pathway, which should end with the transcription and the occurrence of this blockage ending in the nucleus of our patients with psoriasis. Here we see the different classes of JAK inhibitors. We know there are many new drugs in study, each one with its specific safety and efficacy profile. The main concern when we look data of infections with this class of drugs, we know that the overall rates of infections are very similar among all different JAK inhibitor classes, but the reactivation of the varicella zoster virus is one of the most concerning and recognized infections complications when we use this class of drugs. And this is probably secondary to the JAK-dependent functions implicated in the steps of the virus cycle in our patients treated with this modality treatment. This is my last slide. I thank your attention.
Thank you very much. We have time for some questions through the chat, but I would like also to ask you something about your experience with tuberculosis, and especially the need to repeat the testing, either quantiferon or PPD, periodically in some patients. You know, we all know that some guidelines have been put forth, but based on your experience in a country with a relatively high prevalence of tuberculosis, which is your approach in your patients?
Thanks for your question, Professor Puig. This is a very controversial aspect. We know that some guidelines propose that you should annually screen your patients with PPD and quantiferon, and others say that not. I will tell what we do at our department. Normally, we repeat the screening procedures when we have a history of contact of our patients with tuberculosis. So these patients went to endemic area or went to a specific site where the tuberculosis incidence is high, or the patients, of course, has any familiar that develops tuberculosis, then we do all the screening for our patients again. Why don't we do it annually or even more frequently? Because what we hear from the infectiology colleagues is that if a patient should have contact with tuberculosis during his anti-TNF treatment, he would probably develop the full-blown picture of tuberculosis and not just positivating his PPD or quantiferon and being asymptomatic. So it would come in a full-blown picture really when he gets contact with this infection. So normally we just do if there is a specific reason to screen these patients again. Otherwise, we just do the clinical and regular laboratory follow-up.
In the rare instance where you get a latent, so let's say seroconversion, quantiferon becomes positive or PPD becomes positive in a patient with in which you can rule out active tuberculosis, I understand you will start chemoprophylaxis, but will you perhaps, do you stop treatment in those patients?
No, normally we don't stop. We maintain treatment. Here in Brazil, we maintain the prophylaxis with isoniazid during 9 months. In some places around the world, it's 6 months, but normally we don't stop treatment. And we know that before we introduce an anti-TNF treatment, it's regular enough if we wait 4 weeks with the prophylaxis before you start the blockage of TNF.
Excellent, thank you. We have one question from Professor Mrovic.
Yes, Ricardo, thank you for this excellent talk. I have a follow-up question because this is one of the most burning issues also regarding writing our guidelines or renewing our guidelines in this respect. So we just talked about anti-TNFs. And what's your position with the anti-IL-17 and IL-23 class? Because they have shown us data that the risk of getting a latent TB reactivation is very, very low, and even in the threshold of the normal population. What is your, and we are aiming for a long-term treatment paradigm for psoriasis, namely 5 years and more. So what is your approach to a rescreening regarding anti-IL-17 and anti-IL-23s?
Thank you, Ulrich. What we do nowadays, we still screen our patients the same way we always did with anti-TNF blockers. But it's our personal opinion that in the near future, this necessity will probably drop, because we know the incidents are extremely low. We don't check our patients for latent TB when we introduce methotrexate and even systemic steroids for treating lichen planus, for example. We never do this because the rates of reactivation are low. So we know that the main concern is really with the blockage of TNF. It's specific of this class of treatment. But as far as I'm concerned, I think in many parts of the world, it's still mandatory to check for the same way we did in the past. But I think this will have a short-lived history in the future.
This will be for the beginning of treatment, Ricardo. But when you continue for 5 years, do you have the same procedure? You just ask your patients about possible contacts, if they have a traveling history in areas where there is more tuberculosis than maybe in Sao Paulo. Is that what you're doing with the anti-IL-17s and 23s as well?
Yes, exactly the same. We don't screen.
Okay.
And we sometimes observe is that we just screen the patient. The patient is perfectly well, doing well in treatment, and he comes back with a PPD of 6 millimeters, for example. What would you have to do? You would have to start your chemoprophylaxis for 6 to 9 days with a drug we know that has some side effects like liver toxicity. But once you screen and you get a positive result, you can't avoid checking for this result and handling it. So it's sometimes a bigger problem if you just screen the patient without a specific reason to do that.
Okay, thank you very much.
Thank you.
Thank you very much. Excellent talk, a great discussion. Now it's my pleasure to introduce Dr. Salvir Mahil. She's a consultant dermatologist at St. John's Institute of Dermatology, Guy's and St. Thomas NHS Foundation Trust, London, United Kingdom, and adjunct senior lecturer at King's College London, United Kingdom. She is co-director of the PSOProtect and PSOProtect.me global registries and an International Psoriasis Council counselor. And the title of her talk is Experiences from the SARS-CoV-2 Pandemic and How to Apply Them in Future. Dr. Mahil, the floor is yours.
Thank you so much. And thank you very much for the invitation to come and join everybody today. So this is a talk on our experiences from the SARS-CoV-2 pandemic and our learning and how we're going to take things forward. So what became very immediately obvious is as soon as the pandemic came, we urgently needed data. And this is a scenario that, that we had not been in before and was a worldwide issue. So there were specific concerns for our patients with psoriasis. We know that psoriasis is a common immune-mediated disease. Multimorbidity is highly prevalent, and data that came out very early on in the pandemic showed that comorbidities such as obesity, for example, was associated with adverse outcomes. And of course, drugs that affect the immune system are the mainstay of our treatment for moderate to severe disease. But what does this mean in terms of risks of adverse outcomes? And then as the pandemic progressed, the research questions also evolved from this initial concern about COVID-related hospitalization and death to then the great progress that was made with the introduction of the COVID vaccine. But again, there were concerns with that. Are our patients protected from COVID with the vaccine, given the burden of immune suppression that they're on? And the issue of indirect excess morbidity, given the protracted period of the pandemic, with this issue of the mental health burden of the pandemic, and how are our patients being affected by the disrupted access to clinical care. And this is the timeline of the pandemic so far. And as you can see, there have been more than 500 million cases to date and more than 6 million deaths. And this was our research timeline. So we launched SoProtect and SoProtect.me, which are research registries that I'll describe in more detail shortly, in March and May, respectively. And then we launched our vaccine study at the beginning of January 2021. So first, to the registries, we launched SoProtect, which is a clinician-reported registry for any clinician around the world to report their cases of COVID in psoriasis. We also launched an aligned patient-reported registry called SoProtect.me. And again, this was a global effort, and it is an online registry for anybody who suffers from psoriasis to report their experiences of living with psoriasis in the pandemic. It's available in 9 different languages. And thanks to the support of our partner professional and patient organisations, including, of course, the IPC being front and centre of that, and these registries have been truly global efforts. In terms of the data that has come in a very short period of time, we collected a lot of cases, as you can see from the bottom left there. And to date, we've had more than 1,500 clinician-reported cases coming into SoProtect, predominantly from Europe, as you can see there from the pie chart on the right. And with SoProtect.me, we've had more than 5,000 people with psoriasis complete SoProtect.me to date. Around 50% from the UK, but you can see the remaining 50% with a very nice global spread, including South America, North America, and Asia too. So in terms of our findings and what we've learned, so the first thing that we learned was collecting data through an online registry enabled us to rapidly get a lot of data and engage with the global psoriasis community. So we published our first paper in October 2020, and this was focused on that first key issue, which is the factors associated with adverse COVID outcomes in patients with psoriasis. And the first data set that our cut was just under 400 cases that we analysed. We recently updated the analysis with 1,200 cases at the end of last year, and the findings were very much the same. And this reassuringly showed that more than 90% of patients reported to SoProtect fully recovered from COVID. And this is in the context of most of these patients receiving some form of immunosuppression. 70% were on a biologic, 17% on a non-biologic standard treatment. And in terms of the risk factors for hospitalization, we very much saw the same patterns and the same risk factors as were seen and reported in the general population. So more severe COVID was associated with being male, older age, non-white ethnicity, and individuals with comorbidities. And when it came to the drug question, we found that hospitalization for COVID was associated with receiving non-biologic immunosuppressants compared with biologics. And another thing that we learned is the importance of collaborating, not just with investigators interested in psoriasis, but actually beyond psoriasis and across immune-mediated diseases, because of course we use the same treatments, or many of the same treatments. When we designed SoProtect, we aligned our fields with other registries, in particular the Global Rheumatology Alliance COVID registry and the IBD registry called Secure IBD. And because our data sets were aligned, we were then able to perform pooled analyses across the diseases. And this JAMA Network Open paper came out last year, and this was our pooled analysis of more than 6,000 patients from 74 countries, including rheumatic conditions, psoriasis, and IBD. And we found the same patterns that we were seeing in SoProtect. So compared with biologic monotherapy, and here we focused on TNF inhibitors, there was a higher odds of hospitalization or death with individuals receiving co-therapy, so a biologic combined with azathioprine, or azathioprine alone or methotrexate alone. But of course, it's very important to consider the limitations of these registry-based data sets. These observations are not causal, and there may be other unmeasured factors that might be associated with use of biologics. And this is where our patient-reported data was very helpful in helping us to interpret this. There are, of course, selection biases at play, so the data sets are dominated by patients taking biologics. There's no denominator data. The size of these data sets is still limited compared with the global scale of the pandemic, and we weren't able to compare with the general population because we focused on patient-based data sets. So then we moved to the patients, and we learned that it's critical to understand from the patients their experiences and behaviours. And when we started to explore risk mitigating behaviours in the pandemic, we learned actually that shielding behaviour varied between those taking biologics and those taking standard systemics. So those on biologics seemed to be shielding was more common in these individuals compared to those on standard systemics. And this greater risk mitigating behaviour in those on biologics may well have been contributing to the reported lower risk of adverse outcomes that we were seeing in SoProtect. So also going to the patients to get their perspective, we were able to understand the true burden of the pandemic, and 43% of individuals who reported to SoProtect had said that their psoriasis had worsened during the pandemic. And this was associated with anxiety and depression, and we embedded within SoProtect validated screens for anxiety, a GAD-2, and depression, a PHQ-2. And we also found that females were disproportionately affected by this. So moving on from our findings and learning from the registries, we then, at the beginning of January, launched our vaccine study. And this was really because there was again, very limited data on COVID vaccine immunogenicity in people receiving therapeutic immunosuppression. Of course, our patients were excluded from trials of COVID vaccines, and they had already by that time been shielding for large periods due to concerns over their risks of adverse COVID outcomes. There was some research at the time, but it was overwhelmingly focused on seroconversion alone. And we know from other vaccine research that actually seroconversion is just one component of the complex immune response to vaccines. And we knew from before the pandemic that methotrexate impairs serological responses to influenza and pneumococcal vaccines. So would it do the same to the COVID vaccine? So we set up a longitudinal cohort study, and we recruited individuals who were receiving monotherapy with either methotrexate or different biologics. And these were all individuals with psoriasis. And we also recruited a healthy control cohort, and we collected their blood tests before the first vaccination, 28 days after the first dose, and then 14 days after the second dose. We found the sort of, again, the power of collaboration, but really through an interdisciplinary team science approach, we were able to explore this complexity of the immune response. So we collaborated with investigators who already had experimental pipelines in place to investigate vaccine responses from before the pandemic. So we're investigating other vaccines, and we repurposed their pipelines to look at the COVID vaccine, which meant that we could do this at pace. So we looked at humoral immune responses and seroconversion, and importantly, neutralizing responses, and also the cellular immune response, in particular Th1 and T follicular helper cell responses. And we found that after the first dose of the COVID vaccine, and we recruited individuals who had taken the Pfizer COVID vaccine, the spike-specific IgG after the first dose was the lowest in those receiving methotrexate. Then came those who are on biologics, and then came our healthy control cohort. And then when we looked at neutralization activity against wild-type SARS-CoV-2, we found that those who are on methotrexate did have the lowest neutralizing titers, whereas those who are on biologics had titers that were comparable to those who are in the healthy controls. And then after the second dose, we found something again that was interesting. And here, after the second dose, the humoral immune responses actually appeared relatively comparable between those on monotherapy with either methotrexate or biologics and our controls. But when we looked at the total T cell responses, the response rates were lower in patients receiving immunosuppression compared to controls. So 100% of our controls mounted a detectable total T cell response, whereas 29% of the individuals who were taking therapeutic immunosuppression had no evidence of T cell responses. And this calls into question the durability of their antibody responses, because the cellular immune response promotes a durable antibody response. And it really emphasized the importance of subsequent doses of the COVID vaccine in these individuals. So the vaccine's important, and there was lots of other research coming out at the time that showed this for cohorts who were immunosuppressed. So the next question was, well, what do our patients think about the vaccine, and are they taking it up? And here we turned back to So Protect Me. And we found actually very reassuringly that only 8.3% of the patients who reported to So Protect Me were vaccine hesitant. But the individuals who were vaccine hesitant were younger. They were less likely to be taking systemic immunosuppression. They were more likely to be of non-white ethnicity and live outside the UK, and they'd had a shorter duration of their psoriasis. And importantly, they'd had disrupted access to their psoriasis care. And when we looked at the total proportion of those reporting to So Protect Me who reported some sort of disruption, it was more than 40%. So a substantial number of people had had disrupted access in the pandemic. So our research has been able to inform clinical practice thanks to the efforts of other investigators who have been able to pull together all of the emerging research during the pandemic and summarize it for clinicians and produce guidance for clinicians. So one very good example is the National Psoriasis Foundation, which is led by the COVID task force is led by Joel Galfand, who is an IPC counsellor too, and these were able to inform practice during the pandemic. And of course, the IPC statements on COVID and psoriasis have been very important in doing the same, and our findings have also been cited there. In terms of the vaccine data in the UK, this is a UK example, but this green book are guidelines for UK clinicians on all different types of vaccines. And it's a very well utilised national resource. And during the pandemic, an extra chapter was added on COVID, and our research was cited to emphasise the importance of booster doses of the vaccine in individuals who are immunosuppressed. We learnt that disseminating findings simply and using visual means can be very effective. And for every paper that we published, we produced an aligned lay summary for patients and the public, and also infographics. And the infographics were very useful and a succinct way to get across key findings, which in turn can be were shared on social media and through our partner organisations. And we were very active doing PPI webinars to disseminate the findings, recording videos and podcasts, including one with Peter actually here from the IPC. We wrote blogs and press releases, and we're active on social media thanks to our partner patient professional organisations, including IFPA, the Psoriasis Association, and the Global Psoriasis Atlas, who have worked with us very closely to help the dissemination. And finally, our websites have been key to feeding back the data very much in real time. So we keep the websites updated, and there's a current data page for both SoProtect and SoProtect Me, which shows and shares helpful snapshots of the data and links to the papers. And so just finally to thank really everybody who's been involved. The executive committee has been myself, Catherine Smith, Chris Griffiths and Jonathan Barker, and it's been our absolute pleasure to work so closely with investigators internationally, with this fantastic International Scientific Advisory Board and other investigators who have been so key in both feeding in the data, helping us to interpret it and disseminate it rapidly so that it can inform practice. So thank you very much.
Thank you very much for this excellent talk. I would like to ask the attendees to address their questions to a tag on the lower part of their screen. But I have just one very quick question for you. You've done very fine research on the immunogenicity of vaccines in this patient population treated with biologics. Do you believe that in patients with psoriatic arthritis who are more likely to be treated simultaneously with methotrexate and biologics, is there any evidence that the immunity might differ somehow, or that this combination might be superative, for instance, as regards the immune cellular impairment?
Yeah, it's an interesting question, Luis, definitely. So in our cohort, we didn't look at co-therapy specifically for that. It does muddy the water. So there's nothing that I know about in terms of co-therapy. Obviously, the key other agent that they use is rituximab, and there the evidence is quite clear that there's a significant sort of immune impairment. But yes, definitely for the rheumatology community, and sometimes we use it too. It's an important question.
Thank you very much. Well, it's now my pleasure to introduce Professor Ulrich Novich. He's a professor of dermatology and the founder of the Psoriasis Center in the Department of Dermatology at the University Medical Center, Schleswig-Holstein, Campus Kiel, Germany. The Psoriasis Center provides a large clinical trial unit and is part of the Comprehensive Center for Inflammation Medicine at the Kiel campus. Professor Rovich, the floor is yours.
Thank you very much, Luis. And I have a limited time now to jump into my topic, vaccination and immune responses in patients with psoriasis, what we know and what we need to investigate. And we've already heard from Satvir how important some magic words are. And the most important magic word, at least in the beginning and now with a new chapter opening about vaccination, is the gap of data. And of course, it takes a while to get data when a pandemic starts. When you have a vaccine ready to be used in a large population, it will of course take a lot of time to analyze vaccination responses and to see if in diseases such as psoriasis, vaccination responses are as in normal population-based environments, and whether diseases are not only as such, but also treated will affect vaccination responses. And this is that was the topic given to me. And after showing my disclosures, I think the most important questions we have at the moment are psoriasis patients more susceptible for infections such as SARS-CoV-2? And we heard that this may not really differ from the general population, except for severe forms of psoriasis. And therefore, in the beginning, we all try to avoid panic among our patients. And the most important issue of panic is to stop all treatments. And that our advice at this time was to continue with the treatment and contact or the dermatologist or the people in charge of the treatment. And I think what we did at this time with a very, very low database was well taken, and the data that we have just shown from SoProtect and from other registries, I think, showed us that we did a recommendation to our patients that was right at this time and in the retrospect. The second question I think is important: is psoriasis a risk factor for severe causes of COVID-19? And we learned that it's not psoriasis as such, but it's mainly comorbidity that goes along with psoriasis. And, obesity was just mentioned, and we've seen data that, for example, hypertension and other comorbid conditions are more of a risk factor than psoriasis itself. And I think these kind of questions can be answered by data very soon and in a more comprehensive way as we could do this in the past. And now I already alluded to, we have now opened a second chapter of dealing with a pandemic, and this is to offer a vaccination to patients and people. And there are again some important questions to be answered. And the first is, do vaccinations induce a protective response in psoriasis patients in this time? The second is, do medications for psoriasis interfere with vaccination responses? We just heard from first data from the vaccination study within SoProtect that obviously methotrexate is a possible candidate for such an interference with vaccination responses, which was also shown not only for SARS-CoV-2 vaccinations, but for other vaccinations that have been investigated in the past. And I think there's also a third question that needs to be answered, and this is, do vaccines cause flares of psoriasis? And when we look into the Medline database, for example, there are more and more cases popping up showing that indeed, particularly with follow-up vaccinations, there is a maybe increased risk for flares of psoriasis. And I will try to give you some of the data that have been published to answer the questions I have raised. We've just seen these infographics. They're very helpful, as Satvir was already alluding to. And I think the most important and positive outcome of this is that 93% of our psoriasis patients showed full recovery from COVID-19. And I think this is also something that needs to be communicated because, as you've seen, there's a low proportion of hesitant behavior regarding vaccination, But of course, also there is a hesitation to see doctors in the offices or in ambulances in the clinic because of a potential risk of getting infected from others. So this is something we need to communicate. Regarding the burden COVID-19 brought to the people, you've already noted psoriasis worsens by 43% of the patients that reported to the PSOProtect data registry. This is quite an amazing amount, and we've just learned that there may be some aspects of psychological background, such as fear, worries, particularly in females that are more prone to these kind of threats during a pandemic or something that brings a potential threat to communities. So that's also something we need to know to better educate and advise our patients and the patient's environment / families and partners, but also the treating physicians about these issues. Well, I will jump now into this data we have generated, never published. And I think it's very important not only to keep an eye on what happens after the first dose and what happens about the effect of a vaccination against infections, but also about a vaccination response regarding protection of the disease. So this is data published very recently, and that is regarding estimated vaccine effectiveness of RNA-based vaccines against SARS-CoV-2 infection. And here it's shown that after the first dose, we have a protection level, vaccine effectiveness level of about 55% after the first dose, measured 14 days and beyond after the first dose. After the second dose, this level was raised to 48, and after the third dose, the level is up to 69. So that's always what we can call full protection for SARS-CoV-2 infection. So the second important aspect is, does this also protect for severe outcomes? And so severe outcomes of COVID-19 disease. And here in the same publication, we have data after first and second dose. And again, it's displayed as adjusted vaccine effectiveness. And there's again clear evidence that the first dose offers some degree of protection, in this case 72 in this particular publication. But after the second dose, this is really lifted up to 92, meaning virtually full protection against severe outcomes of COVID-19. And it a little bit corresponds to this 93% full recovery after COVID-19 in the PSOProtect. So I think that's very good news for those who emphasize vaccinations, and of course, that's what we all do. There is an interesting Hungarian study that was also published quite recently in a small cohort, 102 patients moderate to severe psoriasis, and in addition, 55 matched controls, and this during biologic therapy. And they all received an mRNA-based vaccine, and data were taken about 10 to 21 days after the vaccination. So they looked into two different categories. First of all, serology, but also a little bit more differentiated. And I highlighted here the line with the IgE serum levels. And what you can see here is, if you look into the whole study population, that there is a vaccine response for sure, increasing the IgE against SARS-CoV-2. But there is a differentiation in the drug classes. And we have here the biologic drug class, and you see that the lowest serum level is during anti-TNF inhibitor treatment, then followed by the IL-17 and IL-23 drug class. And the last one is for ustekinumab. And there is a shift in the level of serum IgEs, and it's highest for ustekinumab treated patients. And quite interestingly, this is a bit backed up by another study in a even smaller cohort, that have looked into the stability of the vaccination response. And it was shown that those patients that were receiving TNF blockers had the lowest stability of the vaccination response in comparison to healthy controls. And these patients were patients with chronic inflammatory diseases from our Kiel Comprehensive Center for Inflammation Medicine. So these included patients with inflammatory bowel disease, rheumatological disorders, but also psoriasis and psoriatic arthritis. And the data were taken after a second vaccination with the BioNTech vaccine. So there is some evidence that some groups of treatments, such as TNF antagonists, but also we've heard about methotrexate, may affect vaccination strategies and vaccine response stability. The vaccination events, and I alluded to this with one of my questions, may not only be beneficial in inducing a response that is protective against infection and disease, but may also bring along some side effects. And that's a recently published study from a Greek center of the Isle of Crete. And it's a retrospective study reporting 12 psoriasis patients with cutaneous side effects after a second dose of the BioNTech vaccine or the AstraZeneca. And the group includes 9 females and 3 males. The mean age were around 44, 43, but a quite long duration of psoriasis. And there's a very short latency between dose and event after the second dose of the vaccines, 13 days only. And the main duration of the exacerbation was 2.5 months. 6 of the 12 patients were on biologic monotherapy. And here is the list of the cutaneous side effects that were observed in the study. And 10 of the 12 patients showed an exacerbation of their plaque psoriasis. What is remarkable is that in 2 patients, there was a pustular flare. And that's more and more now in the form of case reports in the medical databases that psoriasis patients may respond to second, third, and fourth vaccines with a pustular flare. And there's still a tremendous data gap. One patient, interestingly enough, not only showed an exacerbation of plaque psoriasis, but also got a bullous pemphigoid. Whether or not this is really vaccine response related or by coincidence, of course, we don't know. This is a study, again, from our center in Kiel, where we studied 26 patients with IMID, including, as I said, inflammatory bowel disease, rheumatological disorders, but also patients with psoriasis and psoriatic arthritis. And this was after a first vaccination and a second vaccination of the BioNTech vaccine. And this is now a discrimination in IgE, IgA, and neutralizing antibody responses. And in principle, what you can see from the 3 figures is that in the general disease population of the IMIDs that was analyzed here, vaccination responses are quite well and showing an increase of the levels of antibodies that are generated after vaccination, whether this is IgG or IgA, or whether these antibodies are neutralizing. However, there are some single patients depicted down here, but also here and there, where vaccination responses are insufficient. And we still don't know if those patients show a common pattern, if these patients have been treated with special treatments, including systemic steroids, or a combination treatment, for example, steroids plus azathioprine and others, where we could, in the end, find a profile where the follow-up investigation about the vaccination response is somewhat mandatory, and we cannot predict that those patients will receive effective vaccination response. So that in the end brings me to the formulation of my future needs, I think what is really needed is that longitudinal studies are implemented regarding the longevity of vaccination responses. We should not forget that all the vaccines that we have until today, mainly the BioNTech one and AstraZeneca and others, Moderna, they have been generated against the Wuhan virus structure. And now we face the situation that with the Omicron variant, even though patients are 4 times vaccinated with these kind of vaccines, can be infected by SARS-CoV-2 with the Omicron variant and even get mostly a mild cause of COVID-19. So we need to shape our longitudinal studies a bit along the vaccination strategies we were using so far. And of course, we need a better risk assessment of treatments regarding the level of protection against the infection and the disease, and in comparison to a no treatment strategy. And registries such as SoProtect, but also others, and Germany have the Rna-Based registry, should be aligned with each other to get a large database soon to give better answers to those future needs questions. With this, I thank you very much for your attention, and I'm happy to take questions.
Thank you. Excellent talk. Just one question. Based on your educated guess and your clinical experience, is there evidence that some clinical factors, for instance, age and consequent immunosenescence, might modify the risk of, on one hand, depressed immunogenicity following vaccinations, or on the other, perhaps modified risk of exacerbations following vaccination?
Luis, this is a very good question, and I have no answer to both. We have seen also from Satvir's talk that, for example, being of male gender and having more severe disease, being non-white ethnic, having comorbid conditions, these are the patients that are more prone to infections and COVID, but these are also the patients that are more difficult to treat. So that is our difficult patient population. We have no predictors so far, and we neither have predictors of vaccination responses. This is something where we need big data for. And you know that drugs such as rituximab is the only one from which is clearly known that there is a significant impairment of vaccination responses. And we have some evidence for methotrexate, as it was shown during this meeting. We have some evidence for anti-TNFs, as I have alluded to with my data slides from very recent investigations, and we need to back up those with with more data from different countries, from different ethnic groups, and then we have to constantly modify our recommendations that we bring out to the physicians community, dermatology community, how to counsel their psoriasis patients.
Thank you very much. I really enjoyed this talk, all the talks of the webinar, and it's now time to thank you all, the presenters, the attendees, the IPC, and our sponsors, and invite you to keep tuned for the next webinars in the International Psoriasis Council series. Thank you very much. Have a great day.
Thank you. Bye-bye.
Bye.